Good afternoon. My name is Dr. Clement Muka. Today we're gonna talk about elimination of TB in South Africa. This is a plan of the Department of Health of South Africa, which is a wonderful plan. And today I want us to look at the execution of this plan. What is it that we're gonna do to make sure that TB is eliminated? The first thing to think about is the different types of TB, so that we're able to target, we're able to say, the patient in front of me has got active TB. No, the patient in front of me has inactive TB. You know, active TB will have its own symptoms. And inactive TB, it will just lie dormant there without any symptoms. We give it a special name, we call it latent TB. But active TB, what type of symptoms do you normally see? With active TB, we have a patient who coughs persistently. With active TB, we have a patient who has a noticeable weight loss. With active TB, we have a patient who has what is known as loss of appetite. Some people call it anorexia. Patients who have active TB are tired all the time. Tiredness. You know, there's something that you're not going to be able to make out or as a symptom if you don't. You know, to diagnose TB, one has to screen for the condition. Screen for TB to be able to diagnose it. For instance, if you don't ask about night sweats, you won't get any information from the patient if you don't ask. You need to ask. In other words, you've got to screen for that. You've got to ask. And the normal response is, oh, I have drenching night sweats. Drenching night sweats. That's good. That's good for you as a symptom to know that. You wouldn't have known it if you didn't screen for it, ask for it. You wouldn't know whether the patient is tired all the time if you didn't ask for it. These are what, you know, they're given a special name that's known as the TB clinical stigmata. Patient will have a persistent cough. Well, the patient can cough in front of you. Of course, you've got to put on your mask to make sure that you don't. This is an infectious disease. You've got to make sure. But still, you are just looking at the symptoms. Weight loss, you're looking at the symptoms. You have not diagnosed the condition because, the patient will cough. Even if the patient has got bronchitis, the patient will cough. Even if the patient has got just a pneumonia, the patient will cough. If the patient has got bronchiectasis, the patient will cough. If the patient has got chronic obstructive pulmonary disease, COPD, the patient will cough. So you've got to get a diagnosis. So what are you going to say to get this diagnosis? What are you going to do to get this diagnosis? We've got tests to be done. Tests to be done. What test am I thinking about? I'm thinking about a sputum test, a smear test. If it is positive for TB, good. It's normally a very insensitive test. But it's important that you do it, because if it tests positive, it will enable you, when you are treating, to know that now must move from this type of treatment to this type of treatment. It will enable you, because if now it changes from being positive, smear positive, to smear negative, then it will enable, after 2 months normally, we change. We go to another form of treatment and to execute a plan of treating for 6 months. So this is, it's good to know. But how are you going to diagnose now? Okay, you will get a sputum test, a smear test that says positive. That is a test, and that tells you to start treating. But these days there's a bit of sophistry. We are a bit sophisticated. We're using molecular tests. And one of the molecular tests that's so important these days is what is known as gene expect. Gene expect, as we know, it's targeting for, for this this is what are we treating here? Mycobacterium tuberculosis. Mycobacterium tuberculosis has got a genome. And we're targeting a special portion of the genome known as the POB gene. And that portion of the gene, that's what is susceptible to rifampicin. Rifampicin, if it's rifampicin positive, in other words, it's positive for sensitivity, then we know this is your susceptible TB. TB is divided into two, say DSTB and DRTB. DRTB, it's when it is this special portion of the Mycobacterium tuberculosis genome. It is actually not responsive now to rifampicin. When it is not responsive, then we say this is drug-resistant TB. Then we have to look, and this is very important, as a classification. Because you're going to change the format of treatment. When it is drug-susceptible TB, we give what is known as RIFA-4. What is that? RIFA-4. RIFA-4, it means you're going to give 4 drugs. You're going to give rifampicin, you're going to give INH. INH is isoniazid. You're going to give pyrazinamide, you're going to give ethambutol. This is important to know. And this is the type of thing. This classification is very, very important, because you must know now even the type of patient sitting in front of you. Well, is this a baby? If it's a baby, you're not going to use ethambutol, because ethambutol with babies, it causes what is known as optic neuritis, and we don't want that. It can lead to blindness. We don't want that. We don't want that. So with adults, we use our ethambutol as our RIFA, one of the drugs of RIFA-4. And this is good to know. You gonna carry on giving this, but after 2 months, you got a smear positive initial. And that's important. It's a good indicator for you. So that when you do it after 2 months, and you get a smear negative, it tells you, change from RIFA-4, go to Rifina. What is Rifina? Rifina is just to keep the 2 potent anti-tuberculous drugs, that is rifampicin and INH. Keep them. In other words, get rid of pyrazinamide, get rid of ethambutol, and keep these 2. And that's called Rifina. You give Rifina, right? And for the next 4 months, remember the treatment has got to be there for 6 months. Then now, for the next 4 months, you will be giving Rifina, the 2 potent anti-tuberculous drugs. Can't forget this. That's important. That's how to manage these patients. You're doing DSTB. If it happens, remember, we're executing a plan of Department of Health. Department of Health says, we want to eliminate TB. Right? You've dealt with your DSTB. What about DRTB? What about DRTB? When now you get a gene expert result that says, resistance. When you do a gene expert, it says resistance. So in other words, rifampicin is being resisted now. So we're dealing now with a special TB, rifampicin resistant TB. And under rifampicin resistant TB, we've got quite a number of TBs. For instance, we've got pre-XDR TB under this. We've got MDR TB. And MDR TB, once I mention MDR TB, I get worried. Because MDR TB is when you have rifampicin that's being resisted and also INH that's being resisted. But we don't have a result of INH that says it is being resisted. We don't have it. So in the past, we used never to have a problem. We used to do what is known as LPA. LPA is line probe assay. Where we look at two loci. We look at the locus of rifampicin and we do the another locus, that is the INH locus. No, we don't do that now. We've got a specialized test. It's called Gene Expert XDR cartridge. And this one looks for INH. And it also looks for, what will define your pre-XDR. It will look for levofloxacin. Is levofloxacin being resisted? Levofloxacin is moxifloxacin being resisted? If you get any of these, or ofloxacin being resisted, if any of these is being resisted, then we say we've got pre-XDR. This is good to know. This is good. So the Gene Expert XDR cartridge will give me whether levofloxacin is being resisted. In other words, fluoroquinolone is being resisted. And that tells me that this is now pre-XDR. I'm knocking at the door of XDR. Pre-XDR. Once I have a fluoroquinolone that's being resisted, and the fluoroquinolone I've been using is XDR. So sorry, the fluoroquinolone that I've been using is my levofloxacin. So levofloxacin, once it is resisted, then I know I'm at the door of XDR. So it's pre-XDR. But what about, is that the only thing that you get from Gene Expert XDR cartridge? No, you get, your fluoroquinolone. It will tell you whether it's being resisted or it's not resisted. And what else are you getting? You get your INH. So it replaces the LPA, the line probe assay, LPA. It replaces it altogether now. So because we have an answer for INH. INH is also being resisted. So the rifampicin was resisted, and now INH is being, so you have got MDR TB, multi-drug resistant TB. This is good to know. We need to know, how do we diagnose our MDR TB? Remember, the plan here is to eliminate TB. We can't afford not to be able to interpret our tests. We've got to target. We must know what to target. And the only way of targeting is to be able to know that this test will give me this result. Like, for instance, we know that the Gene Expert XDR cartridge will give me two things. Will give me levofloxacin, whether it is being resisted or not. It will give me INH, whether INH is being resisted or not. And if it gives me INH, then I know that I've got my MDR roll, because the rifampicin was already resisted. So now the two potent antituberculous drugs they are being resisted. So I have my MDR, and I know now I have to think of something else. X, what is that? When rifampicin is being resisted, we say we've got rifampicin-resistant TB. And under rifampicin resistant, we've got other TBs. We've got pre-XDR TB, we've got MDR TB, we've got... So it's important to get that rifampicin resistant, to know that the rifampicin is being resisted. That is very, very good. So that you know, when we say, are we still thinking of Rifafor as my TB armamentarium? What are we thinking about now? We're thinking of something new. We're thinking of B-PAL. What's B-PAL? B for bedaquiline. PA for pretorminate. L for levofloxacin. Levofloxacin is my fluoroquinolone I was talking about. And then dash L, linezolid. So that's your B-PAL-L. That's what you're thinking about. Hey, this is now crucially. Remember, we want to eliminate TB. We don't want to make mistakes. We want to make sure that we give the correct treatment for a specific diagnosis. We know now that we're dealing with drug-resistant TB. Knowing that we're dealing with drug-resistant TB, we've got to know that we're going to give B-PAL-L. But when do we give B-PAL-L? Only when we know that, there's something called HB. HB is crucially important if you are to use B-PAL-L. HB is what? Well, that's still hemoglobin. If your HB is less than 8 grams per DL, then we have a big problem. We can't use this wonderful B-PAL-L. We have to send the patient away to the medicine department so that they do blood transfusion. So they normally give, packed cells. We send it to them. Those guys are able. Those guys, they are used to that. They are going to do blood transfusion. They are going to ask for these packed cells and do that. Push up that HB. And when they push up the HB, we want it to be greater than 8 grams per DL. When is that? That's my patient for B-PAL-L. That's my patient. Then I can go on with my B-PAL-L. But if I fail, still, there are other reasons that can make me fail. Not only just HB. There are other reasons that can make me not to be able to use my B-PAL-L. For instance, if we have got extrapulmonary TB, a severe extrapulmonary TB. Can I give you an example of a severe extrapulmonary? TB meningitis, CNS disease. Oh no. So now this patient has got to be channeled to another form of treatment. They call it individualized. It's an individualized long regimen. Man. So you're saying long regimen. So what were you using all along? I was using short regimen. B-PAL-L is short regimen. Because it goes on to 6 months. B-PAL-L. This is good because this is not what we used to do in the past. In the past, patients would go up to 24 months. This is just for 6 months. B-PAL-L. And that's important to know. It is important. So now, if we have a CNS disease, in other words, we have TB meningitis, then we have a problem. We can't use my wonderful B-PAL-L. No, we can't use it. We have to use an individualized long regimen. Who does this? Not us at the primary healthcare level. Not us. We send the patient away to the people who are actually specialized in this. Well, we have a provincial committee, clinical committee that does this. They plan the regimen. We have a national clinical committee that does that. They plan the regimen, whatever. I said individualized long regimen. It's no longer short regimen. Oh, people I can give in my facility. I can give. Right. But of course, you've got to, in consultation with the people who are actually who are treating drug-resistant TB, like me. Right. So, I said TB meningitis. If you have TB pericarditis, that's a severe extrapulmonary TB. That's a severe extrapulmonary TB pericarditis. First of all, you need to be able to diagnose pericarditis. That's a challenge. It means the healthcare worker must be jacked up and know something about reading of an ECG, because you read a pericarditis from an ECG, and you'll be able to do that. You need some coaching as far as that is concerned. You need to talk to people who are knowledgeable about an ECG, electrocardiogram, right? So TB pericarditis is a severe extrapulmonary TB. What else is severe? TB osteoarthritis. TB osteoarthritis, hey man, that's a bone TB. I always remember this one, because there's this grandmother who was pushing the grandson into my consulting room. And I couldn't understand this. This guy is 18 years of age and he's pushed by a grandmother. Says, my grandson, he can't walk. So I'm talking about TB, osteoarthritis, and severe extrapulmonary TB. This patient is not to be treated by us in the primary health care center. Oh no, it's not for us. This patient must be referred to provincial clinical committee to consider, to national, if we can't get in provincial, to national. Oh, I normally refer them to Sizwe. Sizwe that's where it's a center of excellence. Those people, they know what they're doing as far as not really, but drug resistant TB. They are specialists in the area. Drug resistant TB. They manage drugs. They're gonna use drugs that we don't have at all. They use drugs like Delamani, drugs that we don't use at a primary health care. We don't even have them. We just hear about them. Oh, Delamani, they're going to use that and all. And the other drugs that we don't know. And we don't know actually how they manage those patients in those specialized centers of excellence like Sizwe and we can't decide for the provincial council, clinical council. We can't decide for the national council. They are going to help us out with an individualized drug regimen. They're going to help. They're with the individualized long regimen as opposed to PPI-L. Is that all? Oh, TB abdomen. I've had a patient like that. TB abdomen. From the ascites that we saw, he's got a distended abdomen, this guy, and we started, aspirating, started, drawing some fluid from it, and then we started making sure that we sent this to the lab, and then it came back saying, rifampicin resistant, and we had to send this patient away. This is TB abdomen. TB the peritoneum, it's TB peritonitis. And the peritoneum is the one that exudes fluid into the abdomen, and it is that TB peritonitis. TB peritonitis gives rise to TB abdomen. Man, miliary TB, we don't regard it as ours because it's disseminated TB. It's TB that it's difficult to detect. It's a disseminated TB, and we always refer these patients to these clinical committees, like the provincial, like the national, and even to CISWE, right? And so we want to make sure. So this is our approach. Man, I would like to say something about the inactive TB. Remember, we want to eliminate TB. So the inactive TB is a latent TB. When a patient is coughing and all that, when the patient is having, or shall I say, when the patient gets Mycobacterium tuberculosis, the patient gets this TB by the first infection is with the alveoli. Before the patient can have miliary TB, can have it must first of all get into the alveoli. It must get into the lung. In particular, the alveoli. The alveoli, what's that? The Essex. Now there, it will be phagocytosed by an alveolar macrophage. And when it's phagocytosed by an alveolar macrophage, there are two things. The alveolar macrophage will try and make sure that it breaks it down, it fights this. This is the first. Remember, that's part of the inactive immune system. Remember, there's inactive immune system and adaptive immune system. Adaptive immune system takes place or occurs after some time. But this one, the first attack is done by the macrophages, that the innate immune system. So it keeps it there. It keeps it there as inactive TB. It can be there for years, inactive TB. But remember, the aim of the Department of Health is to get rid of this. We don't want to keep anything inactive there. We want, or if it's inactive, we won't have the patient. But we don't want to, when the CD4 count of the patient goes right down, and it happens to our patients, because our patients are normally, some of them are HIV infected, and so the CD4 count goes right down. When it goes right down, this inactive TB becomes activated TB. It becomes like active TB again, which is not what we want. Now, what must we do? Treat it when it is inactive. Treat it when it is latent. How do we treat it? We give INH. INH goes against what is known as mycelium. Mycelium is an acid, is one of these fatty acids which makes Mycobacterium tuberculosis to be non-attackable by bacteria. Amen. It fights against the bacteria. So mycelium keeps the Mycobacterium tuberculosis safe. So how do we fight then this? We fight the very mycelium with INH. We are fighting now latent TB. Let me tell you, if we do this, we treat latent TB, we treat active TB, we treat drug-resistant TB. I can tell you, we are now executing the plan of the Department of Health. Department of Health of South Africa, I can tell you, it's going to improve the whole world. It's going to improve the whole world because they've got a wonderful plan and it needs to be executed. Thank you very much. Thank you very much for listening to me. And I think you have to remember just to, what did I treat? Active TB, Rifafol. What did I treat? Drug-resistant TB. What did I use? Bipal Deshel. When I couldn't use Bipal Deshel because of problems with my HP being low, less than 8 grams per DL. Then I had to resort to my wonderful clinicians, like right, and when I had to treat, I decided, look, am I going to leave this latent TB? No, I'm not going to leave this latent TB. I'm going to treat it with INH to make sure that I am. I want to eliminate TB, and that's it. Thank you very much, guys.